Hi, my name's Todd Oravitz. I'm going to speak to you today about the hematologic system, and I have nothing to disclose. Starting very basically, anemia is simply a reduction below normal for either erythrocyte or hemoglobin concentration, and it's a result of a disturbance in equilibrium between blood loss and production. One thing needs to be remembered considering anemia is that changes in plasma volume can also affect the relative concentration of erythrocytes or hemoglobin, and this is important when you're evaluating patients, and we'll touch more on that in future slides. There are a lot of ways to classify anemia. This is one way. You can really pick any one that works for you, but there are nutritional, hemolytic, and genetic causes. Of course, we'll get into those here. This list is not exhaustive, but iron deficiencies, vitamin B12 or folic acid deficiencies can lead to anemias, chronic illness, poor dietary intake. Hemolytic anemias include glucose 6-phosphate dehydrogenase deficiency, and there are immune causes as well, autoimmune and medication or drug-induced as well. Now, the genetic anemias include sickle cell disease and thalassemia. We will go over these in great detail in some coming slides. Now, when anemia occurs, what does the body do in response? Well, very simply, it wants to maintain tissue oxygen delivery. And how does it do that? Well, it can be via increased cardiac output, a decrease in blood viscosity, and or a rightward shift of the oxygen-hemoglobin dissociation curve, which is on this slide. It lists very nicely the factors that cause the curve to shift either left or right, and in cases of anemia, the curve shifts rightward, which will help facilitate oxygen delivery to tissues, which is the goal when anemia occurs, to maintain that tissue oxygen delivery. Now, polycythemia, simply defined as an increase in red blood cell mass above normal. This can result again from a decrease in plasma volume without an actual increase in red cell mass, but a relative increase in red cell mass, so something important to remember. And there are primary and secondary causes. What happens physiologically in the situation of polycythemia? Well, that increased red blood cell mass leads to increased blood viscosity, and there can be arterial and venous thromboses, which can be quite devastating, especially if the vital organs, brain, heart, lung, or liver, are involved. Now, a primary polycythemia, also known as polycythemia vera, disorder of stem cells that results in just an increased number of normal erythrocytes. So the cells themselves are normal. Oftentimes we see an increase in platelet and leukocyte or white blood cell counts as well, often markedly elevated. Can occur at any age, most common in the 6th or 7th decades of life, so mainly a disorder of older individuals. Often these patients present with thrombosis, again, especially cerebral. Splenomegaly from splenic sequestration is often present as well in these patients, and the incidence is about 1 out of 50,000. Now, secondary polycythemia. This is an increase in red blood cell mass with no other hematopoietic derangement, so platelet count normal, white blood cell count normal. This is actually a normal physiologic response to chronic hypoxia, and this can occur in a lot of situations. People who live at high altitudes, I always think of the Sherpas and Mount Everest. Congenital heart disease, this can occur. I work at a veterans hospital. We have a lot of patients who are heavy smokers who often present with very high hemoglobin numbers. And then things that cause an increase in erythropoietin level can subsequently lead to a polycythemia. Some common renal occurrences include a polycystic kidney disease, hydronephrosis, and any kind of malignant renal tumor. Additionally, uterine myomas, hepatomas, and even cerebellar hemangiomas have been known to cause increased erythropoietin secretion and lead to polycythemia of a secondary nature. Treatment for this, very simply, bleed the patient. Phlebotomy is very effective. Get to that goal hematocrit, then you can proceed safely. Dehydration, again, can aggravate the polycythemia, make the hemoglobin seen even higher, so that needs to be avoided. And then if you have underlying causes that might be able to be modified or treated, given enough time, for instance, smoking cessation can be effective in lowering that hemoglobin preoperatively. Now, thrombocytopenia, again, simply defined as a decrease in number of platelets. Spontaneous hemorrhage, a definite risk below 20,000 platelet count. Platelets below 50,000, definitely associated with an increase in surgical blood loss in the perioperative period. What can cause thrombocytopenia? Well, decreased bone marrow production, increased peripheral destruction of platelets, increased splenic sequestration as well can cause thrombocytopenia. Giving platelets, one apheresis unit or the 6 random unit donor or 6-pack, if you have a 70 kilogram adult, should increase that platelet count by about 50,000. Focusing in now on the decreased marrow production, what specifically can cause it? Well, physical or chemical agents, radiation therapy, chemotherapy, medications with some of the more common being thiazide diuretics or sulfonamides, infections such as hepatitis B, tuberculosis, even sepsis can lead to thrombocytopenia. Chronic disease, chronic kidney or end-stage liver disease can lead to decreased marrow production and result in thrombocytopenia, in infiltration by cancer cells, either primary or a metastatic process. Increased peripheral destruction, again, will lead to thrombocytopenia. Immune-related and non-immune-related causes are one way to group these disorders. In the immune-mediated, you can see infection, medication, autoimmune causes, and non-immune. Mediated include abnormal vasculature and disseminated intravascular coagulation, or DIC, which we'll get into in more detail here as well. Now, some of those immune-mediated causes of thrombocytopenia include infection. Here it can be viral or bacterial, not uncommon. Medications, some of them are common again, include, in this instance, heparin and quinidine. Some of the autoimmune processes that lead to thrombocytopenia include idiopathic thrombocytopenic purpura, or ITP, and rheumatoid arthritis. While we in anesthesia often focus on the cervical spine in these patients, we need to remember that thrombocytopenia can occur in this patient population as well. Some of the non-immune mediated causes, abnormal vasculature. If you work in a burn or trauma area, you're going to see injury from crush or burn most likely result in thrombocytopenia. Again, in my hospital, we do a lot of we have a lot of vascular paths, and endovascular AAAs are commonly done. Those large grafts can lead to platelet destruction and thrombocytopenia. DIC again, and then thrombotic thrombocytopenic purpura, or TTP, can lead to thrombocytopenia, as well as the classic HELP syndrome of pregnancy. We've all learned about hemolysis, elevated liver enzymes, and of course the low platelet count right there in the name. Now, shifting gears a little bit to thrombocytopathy. This is a qualitative rather than a quantitative platelet disorder. The end result, a defective clot formation and tendency to bleed in these patients, congenital and acquired causes, and of course we'll cover both. Von Willebrand's disease is the most common inherited platelet disorder. Has an incidence of about 1 in 500, so a pretty common process, something you'll certainly see in your patient population, most likely. Patients with severe disease, and there are 3 types, we'll cover them shortly, will present with some kind of spontaneous mucosal bleeding, often epistaxis, but can be also oral GI or GU as well. In these patients, the decrease in the von Willebrand factor leads to bleeding. Laboratory evaluation includes a lot of the measures of coagulation, such as bleeding time, platelet count, PT, PTT, but also needs to include level of factor VIII and von Willebrand activity, and we'll get to that shortly. Types 1, 2, and 3 again in von Willebrand disease. Now, this very busy slide included for your reference the coagulation cascade. The extrinsic, intrinsic, common pathway is still a nice way for us to delineate the coagulation cascade in our minds and a way to compartmentalize things, but again, in vivo, a little more fluid and more interactive perhaps than the slide leads us to believe. But von Willebrand factor specifically is a plasma glycoprotein, important in that pathway, really is the beginning of platelet adhesion to the vascular surface when there's an injury, and also serves as a carrier protein for factor VIII. Now, type 1 von Willebrand's disease is the most common, about 80% of our cases. There's a mild or moderate quantitative decrease in plasma von Willebrand factor activity when measured, but the other labs are generally normal. And this variant of von Willebrand's disease thankfully responds very well to desmopressin or DDAVP, which very simply promotes release of the von Willebrand factor and leads to usually normal platelet activity. Now, type 2 von Willebrand's disease, about 20% of the cases, so a lot less frequent. Many different subtypes here, but they all have a qualitative von Willebrand factor defect, and there are varying degrees here of decreased factor VIII activity with the type 2 von Willebrand's patients. Here, DDAVP is ineffective, and the patients need factor VIII concentrate in the perioperative period to keep the bleeding from becoming excessive. Now, type 3 von Willebrand's disease, quite rare, thankfully on the order of about 1 out of 1,000,000 patients, so again, very infrequent. These unfortunate patients have the recessive phenotype. They have 2 parents, each with mild disease, and they get that gene that leads to the severe form. They have essentially no detectable von Willebrand factor and often very low or even no detectable factor VIII as well. And in these cases, you absolutely must give factor VIII concentrate to replace those factors and allow coagulation to be normal. Now, some acquired cases and instances of thrombocytopathy. Chronic systemic disease can lead to this. Uremia, not uncommon. Not uncommonly will lead to thrombocytopathy. And in this situation, the believed mechanism is guanidinosuccinic acid, which is a metabolic byproduct of arginine that's not sufficiently cleared because of the renal disease, and this ends up inhibiting platelets by nitric oxide release. A very complicated mechanism, but thankfully a very simple fix. Again, DDAVP or desmopressin will allow these patients to have normal coagulation. Liver disease can be also a cause. This is common because those liver patients, especially the end-stage liver patients, will often exhibit hypersplenism, bone marrow depression as well, and often have significant problems with malnutrition. Medications can cause this, aspirin and NSAIDs, we'll get into those more. And antibiotics, some of the more common would be penicillin and cephalosporins. Now, some other, moving to clotting disorders and a congenital factor deficiency. We all know about the hemophilias. There are three types, A, B, and C, factors 8, 9, and 11 respectively, with the vast majority really of cases being type A, 85%, and type B and C a lot less frequent. Now, hemophilia A, that deficiency of factor VIII, unfortunately, is an X-linked recessive disease, so the males listening, about 1 in 5 to 10,000 incidents. Spontaneous hemarthrosis, so bleeding into the joints, clinical hallmark of this disease. And most commonly causing death are intracranial and intracerebral bleeding situations. There's a gradation of disease, mild, moderate, and severe in hemophilia A. The mild disease patients only have about 5 to 30% of normal factor VIII present, but despite that low level of factor, often only have abnormal bleeding after trauma, for instance. Moderate disease in hemophilia A, those patients exhibit only about 1 to 5% of factor VIII levels, and these patients will occasionally have spontaneous bleeding. Now, the severe cases, and again, most patients have severe disease, and again, hemophilia A, about 85% of the hemophilia cases in total. And I apologize, that should be an 8 there. The factor VIII level is less than 1%, and these patients will frequently present with spontaneous bleeding. Now, the PTT in these patients is prolonged, the intrinsic pathway with factor VIII deficiency. The PT since it's the extrinsic pathway, stays intact, so that stays normal. Factor VIII concentrate is the treatment of choice prior to surgical procedures. And female carriers can be at risk for excessive bleeding after surgery, during and after surgery, with hemophilia A. Now, hemophilia B, factor IX deficiency. Christmas disease is another name for this. Also X-linked recessive, much less frequent in the male population, about 1 to 50 out of 100,000. Basically indistinguishable clinically from hemophilia A, so those spontaneously bleeding episodes, the hemarthroses, diagnosis here made really via lab values. Mild, moderate, and severe disease present, again, just like hemophilia A. The PT, since the extrinsic pathway is intact, stays normal. The PTT, because of factor IX being involved in the intrinsic pathway, becomes prolonged. Factor IX concentrate prior to your surgical procedures is the treatment of choice. Now, hemophilia C, factor XI deficiency. This is an autosomal recessive, so there is an equal male-female distribution. Quite rare, again, less than 1% really of the hemophilia cases in total, can affect up to about 5% of Ashkenazi Jews, however. These patients with hemophilia C will have a lot less spontaneous bleeding episodes, and hemarthroses are quite rare. In fact, males often only present after trauma or surgery with bleeding problems, and females can be prone to bleeding complications after childbirth or with menorrhagia. Treatment here is FFP to replace that factor XI deficiency. There are a few other congenital factor deficiencies. They include factors 5, 7, 10, and 11. These are, again, very, very rare, on the order of 1 to a million or less in frequency. And all of them, FFP is the treatment of choice to replace that deficient factor. Now, acquired factor deficiencies. We can start with vitamin K deficiency. And this is important because vitamin K is necessary for the liver to be able to synthesize factors 2, 7, 9, and 10. It occurs in two forms, leafy green vegetables, and thankfully it's made by our normal intestinal flora. Now this means that normally poor nutrition alone will not result in vitamin K deficiency. However, if the normal gut flora is out of number, for instance, because of antibiotic administration, when this occurs with poor nutrition in tandem, this is when you usually see the vitamin K deficiency becoming a problem. There can be causes other than antibiotic administration in the GI tract, obstruction, malabsorption. Biliary problems as well can cause a problem because vitamin K is a fat-soluble vitamin, needs the bile salt for jejunal absorption, so also those biliary problems can manifest as a vitamin K deficiency. The factors are lost and become depleted in the order of their respective half-life. So factor 7 with a half-life of only about 6 hours is the first to be depleted, followed by factor 9 that has a half-life of about 24 hours, and then factor 10 and 2 have much longer half-lives, even than factor 9. So because of factor 7 being lost, there's a prolongation of the PT, factor 7 being involved mostly in the extrinsic pathway. And as that becomes depleted and then the time course becomes longer, factor 9 will be depleted, and then the PTT goes up because that's the intrinsic pathway, factor 9's participation. How is this treated? Well, you can give intramuscular or intravenous administration of vitamin K. Within 8 hours, again, because that half-life of factor 7 being about 6 hours, you should see improvement. And if you're in an emergent situation where surgery cannot wait that 8-hour period, fresh frozen plasma will provide the factors that are deficient, and it is safe to proceed. Acquired factor deficiencies. Chronic liver disease here presents a multifactorial problem. All the clotting factors in our bodies, except for factor VIII, are made in the liver, and factor VIII being made in the endothelium. And vitamin K deficiency, as just described, can also contribute in these situations. But another important point that needs to be remembered is that the inhibitors of coagulation, specifically antithrombin 3 and proteins C and S, are also made by the liver. Now, why is this important? Well, without the inhibitors of coagulation in normal numbers, coagulation is more likely to happen, so these patients can also form thrombus and have problems because of that. And it's difficult at times to remember that the patients with liver disease, you mostly think they tend to bleed, but that you can easily have a patient with significant bleeding problems that also can have thrombus and also have problems of hypercoagulability at the same time. DIC and systemic fibrinolysis also can occur in these patients. We'll touch on that more coming up. What is the problem in DIC? Well, it's very basic terms. The balance of clot formation and degradation is upset. Normally, there are devastating thromboses, but you can also see devastating bleeding, and sometimes you see both at the same time, which can be extremely problematic clinically to deal with. The process of DIC starts in every situation with tissue factor release, and the next slide is going to talk about sources, and this leads early on to excess thrombus formation. Now, the normal pathways for coagulation inhibition are then overwhelmed, and the cascade starts. Here is that list of things that can induce DIC. For reference, this is not complete. It is a lot of the causes. There are others, but as you can see, a lot of instances ranging from sepsis with either gram-positive, gram-negative bacteria, cardiac arrest, placenta previa abruption, things that you're going to occur in your OB practice, can all precipitate DIC. So again, that rapid clot formation early on causes tissue ischemia, platelets and clotting factors begin to be consumed, the fibrinolytic system gets activated, and then fibrin degradation products start to circulate. Now, those products lead to impairment of both thrombosis and platelet aggregation, which ultimately leads to bleeding. And so you can have this combination of bleeding and thrombus at the same time. Again, extremely problematic. How do we diagnose DIC? Well, the PT, PTT are universally elevated. Oftentimes, platelet count is extremely low. Fibrinogen level will be reduced. Again, you can look for the fibrin degradation products or D-dimer in the bloodstream. And then you also always have to remember the clinical correlation of what's going on. Did one of those events that occurred on that previous slide from a couple slides ago recently happen? Do you have a woman who just gave birth who did have a placenta previa, for instance? How do we treat DIC? Well, it's important to try to find the underlying cause, because then you can try to treat it. If bleeding is a major problem, sometimes you have to give FFP or platelets or both. Heparin can be used. This is usually reserved for the patients with problematic thromboses, and those patients often already have a tendency for thrombus as well, such as having an underlying malignancy. Antifibrinolytics should not be administered in DIC. And unfortunately, the natural history of the underlying disorder is often not changed, and that list again had some bad clinical situations on them: cardiac arrest, aortic aneurysm. So oftentimes the outcomes are not good despite aggressive treatment. Just again, another refresher of the coagulation cascade, looking at that extrinsic, intrinsic, and common pathways. Now, fibrinolysis, what is that? Well, it is breakdown of thrombus. And this is part of the normal coagulation cascade to dissolve or remodel clot as needed. And in certain circumstances, however, and surgery can be one, cardiopulmonary bypass is another, the plasmin activation that's involved with fibrinolysis becomes systemic rather than a localized phenomenon, and then bleeding ensues. Some associated conditions, again, as I mentioned, surgery. This can happen in trauma. Chronic liver disease patients often will exhibit fibrinolysis. Cardiopulmonary bypass, as I mentioned, and then specifically resections for prostate cancer can lead to fibrinolysis. Can be very difficult to establish fibrinolysis with the traditional labs, such as PT and PTT, and so one method that's often used and is very good in this situation is thromboelastography, or TEG. Now, this allows real-time assessment of all the aspects of coagulation. Really came to being clinically during liver transplantation at the University of Pittsburgh in the early and mid-1980s. Its usefulness has become validated, and now it's much more commonly used as well in cardiac surgery and trauma situations. Again, very helpful to diagnose fibrinolysis because it's such a complex situation with multiple potential contributing factors. Here's a schematic of some typical tracings, TEG tracings. There in the upper left, you see A, which is a normal tracing. B, the thicker deflection of the tracing, is seen in hypercoagulable states. C, the thinner tracing, is your hypocoagulation for whatever cause. And then D is your fibrinolysis. So the little green deformation there off the straight line represents a clot that then is lysed and goes back to a straight line, which represents no clot formation. So what do you do in situations of fibrinolysis? Well, there are two medications that can be used to treat it. Epsilon aminocaproic acid and tranexamic acid are both available. Synthetic lysine analogs that competitively inhibit the binding of plasminogen to fibrin, and this prevents fibrinolysis. They both inhibit the conversion of plasminogen to plasmid again by acting as a competitive antagonist at that lysine protease. Now, epsilon aminocaproic acid is renally excreted, about 2/3 unchanged in the urine, half-life of about 2 hours. Tranexamic acid, also renal elimination, but about 95% unchanged in the urine. More potent than epsilon aminocaproic acid, both very effective if given in appropriate doses. Right, shifting gears now to anticoagulants. Kind of the prototypical long-used warfarin inhibits hepatic synthesis of those previously discussed vitamin K-dependent factors 2, 7, 9, and 10. Protein C and S synthesis are also blocked by warfarin, and it is easy to monitor therapy with the PT and INR, as the vitamin K dependent factors are found in the extrinsic and common pathways. Now, warfarin undergoes hepatic metabolism, has a quite variable half-life, 20 to 60 hours, and you may remember from orally dosing warfarin for your patients that it can be difficult to achieve a steady state therapeutic level, and a good part of that is this quite variable half-life. Administration of vitamin K will lead to a slow offset of warfarin effect. If you have time, for instance, in a non-emergent situation, perioperatively, if you need to acutely reverse it, fresh frozen plasma can be used. Heparin, another anticoagulant very commonly seen in and around the operating room. Unfractionated heparin comes to us from bovine lung or porcine intestinal mucosa. It binds antithrombin and greatly accelerates and exaggerates its anticoagulant effect. In fact, the heparin antithrombin complex will inhibit factor 2 and activated factor 10 about 1,000 times more than antithrombin alone, so it really exaggerates that effect. It's cleared by the reticuloendothelial system, metabolized by the liver, has a half-life of about an hour and a half. Results in a dose-dependent prolongation of both the PTT and activated clotting time, and the ACT is what's used in cardiac surgery to monitor heparin activity for cardiopulmonary bypass. Heparin-induced thrombocytopenia can occur in up to about 5% of patients who've received heparin. Very serious clinical situation caused by an autoantibody against platelet factor 4 in complex with heparin. These antibodies activate platelets, leading to potentially catastrophic arterial and or venous thromboses. HIT should be confirmed with antibody testing if it's suspected. Non-heparin anticoagulation, perhaps with argatroban or fondaparinux, can be started if it's present. Patients should then be transitioned to warfarin because there is an ongoing risk of thrombosis after the initial suspicion occurs. And really, it should be at least 2 to 3 months for all patients, and possibly out to as far as 6 months if a thrombosis has occurred. And you also need to keep in mind that the reason the heparin was used in the first place for whatever pathology was present may still be present. Another reason for that transition to warfarin. Now, how do we antagonize heparin? Well, protamine is used. This was originally isolated from salmon sperm, and very simply, it's a base. Heparin is an acid. They form a bond, and very nicely, the heparin is removed effectively from circulation, and its anticoagulant effect is no longer present. Standard dosing, 1 milligram of protamine per 100 units of heparin. So standard cardiopulmonary bypass dosing, for instance, is 300 units of heparin per kilogram. So if you have a 100 kilogram patient, they need 30,000 units of heparin. The reversal dose would be 300 milligrams of protamine. Now, very frequently you see a mild systemic hypotension with protamine administration. Rarely, pulmonary hypertension occurs, and this is thought to be from heparin-protamine complexes causing thromboxane release. If this occurs, this usually will result in quite profound pulmonary hypertension, and in the instances I've seen this, necessitated a brief return to cardiopulmonary bypass because of right heart failure due to the nature of the degree of the pulmonary hypertension. Allergic reactions to protamine are more frequent in those who've had prior exposure to it. Fish allergies, as mentioned, the salmon sperm being the source, and those diabetics that have used NPH insulin, because the NPH, the P in NPH, in fact stands for protamine. Now, there is a low molecular weight heparin that is made by enzymatically or chemically splitting the unfractionated heparin molecule into a smaller molecule. That low molecular weight heparin antithrombin complex inhibits activated factor 10 much more than factor 2. So in this situation, PTT monitoring is not useful because the intrinsic pathway is not affected. Renal clearance still is the mode of elimination for low molecular weight heparin, so we need to be careful in dosing these patients over multiple days who have severe kidney disease. There is a lower incidence of heparin-induced thrombocytopenia with the low molecular weight heparin patients. Protamine only provides partial reversal. The agents we see in the United States, enoxaparin or Lovenox, dalteparin or Fragmin, and tinzaparin or Inhohep. These can be monitored with drawing of anti-factor 10A activity levels. Now, another anticoagulant, fondaparinux, binds to antithrombin, increases its ability to inhibit activated factor 10, does not bind to factor 2 or prothrombin. It does not interact with either platelets or platelet factor 4, so there's no risk of hit. Half-life is about 15 to 17 hours, so it is convenient for once-a-day dosing. Again, renal clearance for fondaparinux, unchanged in the urine. We have to watch in patients with chronic kidney disease. Lab values here will be normal, PT, PTT, ACT, and there's no reversal agent. Now, direct thrombin inhibitors, another class of anticoagulants. Thrombin plays a very central role in coagulation, causes platelet activation, stimulates activation of factor 5, causes release and activation of factor 8 from von Willebrand factor, and stimulates activation of factor 11, which in turn activates factor 9. So the direct thrombin inhibitors bind to and inhibit thrombin. Direct thrombin inhibitors, no heparin cross-reactivity, no binding with platelet factor 4. There is no antidote either. Now, hirudin was the first isolated, found in leech saliva. Lepirudin is a recombinant hirudin made in the lab. Unfortunately, it's no longer available. In 2010, was discontinued because Bayer could not get any lepirudin from the original manufacturer, so it is just no longer available. Other direct thrombin inhibitors. Argatroban has a half-life of about 40 to 50 minutes. Hepatically metabolized and excreted will result in prolongation of PT and PTT. And HIT patients given argatroban had significant reduction in death, amputation, new thromboembolic events, so a useful medication in those patients. Bivalrudin is an amino acid peptide sequence that's an analog of hirudin. Short half-life, about 25 minutes, primarily used during percutaneous coronary intervention by our cardiologist colleagues, can be measured and monitored with either PTT or ACT. Dabigatran, or Pradaxa, is the only orally available direct thrombin inhibitor. Has a half-life of about 12 to 17 hours, is renally eliminated, about 80% excreted unchanged in the urine, can be monitored with PTT or ACT, and is used often to prevent or treat DVTs, as well as for stroke prevention and AFib. Now, the glycoprotein 2B3A inhibitors, they work by binding to the glycoprotein 2B3A receptor. This is found on the surface of platelets. It's part of the final common pathway for platelet aggregation and clot formation. Fibrinogen binds to activated GP2B3A, leading to platelet cross-linking as clots begin to form. Now, first example, abciximab, or RioPro. This is an FAB fragment. And what is an FAB fragment? It's a fragment antigen binding. And this refers to any arm of an aminoglobulin monomer. But this is a Fab fragment of a chimeric human murine monoclonal antibody. Has a half-life of about 30 minutes, but an antiplatelet effect that can last from 12 out to 48 hours. Now, this is because abciximab will remain in circulation and kind of move from platelet to platelet. So despite that half-life being short, the antiplatelet effect can be quite long. Thrombocytopenia does occur in patients given abciximab about 2% of the time. Tirofiban, a synthetic non-peptide antagonist, has a half-life of about 2 hours. Is excreted mostly unchanged in the urine. So again, we need to adjust our dosing downward in patients with especially significant renal impairment. And it has a less than 1% incidence of thrombocytopenia. Eptifibatide, or integralin, is another synthetic cyclic heptapeptide antagonist of the GP2B3A receptor. Has a half-life of about 2.5 hours. Again, excreted renally, about 75% unchanged, but also partially hepatically. Very low incidence as well of thrombocytopenia. Some other antiplatelet agents, cyclooxygenase inhibitors. These work by preventing synthesis of thromboxane A2, which stimulates platelet aggregation and is also a potent vasoconstrictor. The two prototypical compounds in this category, acetylsalicylic acid, or aspirin, and as well the non-steroidal anti-inflammatory drugs, or NSAIDs. Now, aspirin binds irreversibly and inhibits cyclooxygenase. The non-enteric-coated oral preparations of aspirin will produce an antiplatelet effect about 1 hour after ingestion. Now, this effect will last for the entire duration of platelet life, which is about 7 to 10 days. The NSAIDs, including ibuprofen, ketorolac, naproxen, for instance, there are others, these have a reversible effect on cyclooxygenase. So here the return of platelet function correlates with medication half-life as opposed to platelet half-life in the case with aspirin. Phosphodiesterase inhibitors will result in increased levels of cyclic AMP, which is an inhibitor of platelets. Dipyridamole is the prototypical agent in this category. Very weak reversible platelet effects are also seen with aminophylline by this mechanism, as well as theophylline and caffeine. All right, Another class of antiplatelet agents, the thienopyridines, they inhibit binding of adenosine diphosphate, ADP, to the platelet receptor P2Y12, which then inhibits platelet aggregation. So these are the ADP receptor antagonists. Used in the United States, clopidogrel or Plavix, ticlopidine or Ticlid, and prasugrel or Effient. There is no antidote for these agents. Clopidogrel, after a loading dose of 300 milligrams for your standard 70 kilogram adult, there will be platelet inhibition within 2 hours. Clopidogrel is hepatically metabolized and has a half-life of about 8 hours. Ticlopidine really has fallen out of clinical use because of the risk of both neutropenia as well as thrombotic thrombocytopenic purpura in patients that it had been administered to. Now, coagulation, coagulopathy in trauma. Frequently, trauma patients will exhibit coagulopathy, and in fact, trauma-induced coagulopathy is an independent risk factor for death in these patients. Global tissue hypoperfusion certainly plays a very central role, and we'll get into that more here immediately. There is endothelial release of thrombomodulin and activated protein C in these situations meant to prevent thrombosis in the microcirculation. Now, that thrombomodulin will bind thrombin and prevent it from cleaving fibrinogen. Activated protein C blocks the extrinsic pathway via effects on factors 5 and 8. And the schematic just goes over that and gives a little graphic representation of the role of thrombin in coagulopathy and trauma. Additionally, hyperfibrinolysis occurs in these patients via tissue plasmin activator or TPA. Endothelial release due to injury or hypoperfusion can cause release as well, and fibrinolysis starts after plasminogen cleavage. Now, activated protein C, again also present, as mentioned in the previous slides, in trauma situations, inhibits plasminogen activator inhibitor 1, or PAI1. So, lower levels of PAI1 lead to increased levels of TPA, which further cascade and feedback to increase the amount of fibrinolysis that occurs. This schematic, again, shows the role of both TPA and PAI1 in just a nice graphic representation here of the information presented on the prior slide. Now, in trauma, there can also be a dilutional component to the coagulopathy. Platelets are more likely to be affected, but any of the coagulation factors can be affected if they're diluted far enough. And this is where a dynamic assessment of coagulation becomes very helpful. As I talked about with TEG, the PT, PTT measurements, bleeding time, platelet number can be first take longer to come back, and they're just looking at one aspect of that coagulation cascade. And in this dynamic, as most trauma situations are, dynamic coagulation situation, it's nice to have that TEG, which you can really look at all aspects together, try to best figure out what's going on and pinpoint it and try to treat it. Now, hypothermia often plays a role in these patients as well, in coagulopathic patients in trauma. If you live in the colder climes, traumas can happen in the colder months, and it often becomes problematic when the temperature is below 33 degrees centigrade. Even in the warmest climates, if you have patients who have large enough trauma, exposed viscera, etc., it's not hard for patients to get to that temperature or lower. Metabolic acidosis plays a role in coagulopathy and trauma also. In fact, it's the only factor that correlates with development of trauma-induced coagulopathy. The effect is by enzymatic inhibition, and when the base deficit was more than 6 milliequivalents per liter in one study, 20% of patients, in fact, develop coagulopathy. DIC, disseminated intravascular coagulation, may also be a problem in trauma situations. And again, I had that slide that had the multiple causes. Trauma is one of them, but there are many, many others. So supportive care and then an investigation for other causes in addition to the trauma, which unfortunately may be the sole cause as well of the DIC. Changing gears now to the hemoglobinopathies. Sickle cell disease occurs when there is an abnormal hemoglobin protein. And the normal hemoglobin protein has 2 alpha and 2 beta subunits. Now, in sickle cell disease, there's a single substitution of a valine for glutamic acid in the 6th position of the beta globin protein, and this results in an abnormal hemoglobin, hemoglobin S, replacing the normal. Homozygous patients that have 2 hemoglobin S molecules will have disease. Heterozygotes will be asymptomatic. Now, the problems in sickle cell disease occur under low oxygen conditions, and that is because that low oxygen condition results in a conformational change in the abnormal hemoglobin S protein. The erythrocytes take on a characteristic sickle shape, which can make their transit through the microcirculation much more difficult, and this will lead to hemolysis. Red blood cell life in patients with sickle cell disease averages about 14 days, which is significantly less than the average 120 days for patients with normal hemoglobin molecules and normal red blood cells. So these patients almost universally will exhibit hemolytic anemia because of that very shortened red blood cell life in circulation. Now, what occurs in sickle cell disease? Well, the painful crisis is a very difficult clinical problem. The sickle red blood cells cause capillary venous occlusion, very small capillaries. There's local microinfarction, which results in ischemic tissue pain. Over enough time with enough microinfarction, there can be organ malfunction. And in fact, most patients with sickle cell of any long-standing nature usually exhibit an autoinfarction of their spleen. Renal failure is also very common in these patients, as there are repeated microinfarcts and tissue injury in the kidneys. Acute chest syndrome is another difficult situation that arises in patients with sickle cell disease. The signs and symptoms include chest pain, dyspnea, tachypnea, hypoxemia, and this happens when there is sickling of red blood cells in the lung circulation, in the pulmonary circulation, causing pain and also temporary pulmonary dysfunction. The difficulty with acute chest syndrome is it can mimic pneumonia, sometimes pulmonary embolism, sometimes myocardial ischemia or infarction as well. So it can be very difficult clinically to try to tease out and figure out what is going on in these patients. Now, how do we treat sickle cell disease? Well, the painful crises usually respond quite well to nonsteroidal anti-inflammatories. Opioids are needed in a certain number of cases. Hydration will usually help the microcirculation and cut down on the amount of sickling and local microinfarction. Supplemental oxygen as well can help, and transfusion if the anemia is significant enough. Acute chest syndrome is treated with supplemental oxygen, again transfusion depending on the hemoglobin level. Bronchodilators can have a positive effect, as will antibiotics, as oftentimes these patients will exhibit a pneumonia along with the acute chest syndrome concurrently. In general, patients with sickle cell get mostly supportive care. If patients exhibit severe disease at an early age, bone marrow transplantation can be done. It has been done from a matched sibling and has been curative. But again, usually those patients who get to bone marrow transplantation are exhibiting severe disease at quite an early age. Hemoglobin C, another variant of that hemoglobin protein where lysine replaces glutamic acid at the 6th position of the beta-globin protein. This results in hemoglobin C. Now, hemoglobin C is more stable than hemoglobin S, and homozygotes will have few, if any, symptoms if they have 2 hemoglobin C molecules. However, patients that have 1 hemoglobin C molecule and 1 hemoglobin S molecule can exhibit disease in severity approaching that of sickle cell disease. Now, thalassemia. This is an inherited disorder of alpha or beta globin synthesis. They all result in the same thing, which is abnormal hemoglobin molecules. The thalassemias are more frequent in Mediterranean, Middle Eastern, and Southeastern Asian regions, and the result is very similar to sickle cell disease, which is shortened lifespan of erythrocytes and a result in anemia. In addition to that anemia, patients can have splenomegaly, hepatomegaly, and jaundice. Sometimes they exhibit bone marrow hyperplasia because of the attempt to increase red blood cell number. This can lead to growth retardation, facial dysmorphism, as well as pathologic fractures even at a young age. There can be extramedullary bone marrow that can bleed, found in the pleural space, the epidural space, and even there have been instances of a paranasal sinus bleeding caused by extramedullary bone marrow in thalassemia patients. The disease severity here, there is a major, intermediate, and a minor degradation. The beta thalassemia major patients will almost universally require lifelong transfusion. And along with that, chelation therapy because of the iron excess that comes from the blood transfusions over time. Pathophysiology here is very similar to sickle cell disease with the anemia, painful crises, acute chest syndrome as well can be a big problem in the beta thalassemia major patients. Now, beta thalassemia intermedia is a milder phenotype. These patients often do very well without any transfusion whatsoever. And the lucky patients here exhibit beta thalassemia minor, or also called beta thalassemia trait. These are patients who are heterozygous. They only have 1 abnormal alpha or beta globin molecule, and they're asymptomatic. Porphyrias. This is an inherited disorder of heme synthesis. They result in excess porphyrins from deficiency of any of the number of enzymes that are involved in the heme production pathway, and there are very, a good number of protein enzymes that are involved in this pathway. And these are almost all exhibit autosomal dominant genetics. They are classified, the porphyrias, as acute or inducible situations or non-acute, non-inducible situations. Cutaneous manifestations are very common in these patients. They'll have fragile skin and exhibit easy bleeding. The non-inducible, non-acute porphyrias, thankfully, there are no acute crises that are involved and no neurologic involvement. Now, the acute or inducible porphyrias, however, are more severe, and symptoms often occur due to drug exposure. They are more frequent in women, typically seen in the 3rd to 4th decades of life, and they include acute intermittent porphyria, a variegate porphyria, and a hereditary coproporphyria. Now, all of them present similarly in the acute situation with somewhat vague abdominal pain, nausea, vomiting, mental status changes. However, then there can be autonomic dysfunction, electrolyte abnormalities, typically hyponatremia or kalemia, and then the real severe things, the peripheral neuropathies. Patients can have hemi or quadriplegia. There have been cases where respiratory muscle paralysis led to death in these patients. Why is this important for anesthesiology? Well, medications that can trigger them are ones that we have commonly used in anesthesia. The barbiturates, certainly not as commonly used anymore. Thiopental for induction, for instance, actually quite difficult to get and used clinically. Etomidate certainly still used, although perhaps falling a little bit out of favor. Hydralazine, very commonly used antihypertensive medication. Fasting and dehydration can lead to acute porphyria. Infection, alcohol consumption, periods of stress. Now, since there are medications that can trigger it in anesthesia, what is safe? Well, propofol has been used in these situations and is safe, as well as ketamine. Local anesthetics, muscle relaxants, the inhalation agent isoflurane has been used and is very safe, as are the opioids. Generally, in these patients, most practitioners avoid regional anesthesia so as not to exacerbate any pre-existing neuropathies that might already exist in these patients. Okay, massive transfusion, defined as replacement of at least one blood volume within a 24-hour period. What are the potential problems or risks with that? Well, you can have hemolytic transfusion reactions. You can have TRALI, or transfusion-related acute lung injury, because of blood transfusion. Certainly disease transmission, hepatitis, HIV, very serious. Thankfully, in this country, very, very rare. Hypothermia, if enough blood is given and is not sufficiently warmed prior to administration, can be a problem. And then there can be a whole host of metabolic problems, including but not limited to hyperkalemia, of course, from stored blood. The longer blood is stored, the higher its potassium content. Both acidosis and alkalosis can be seen, and citrate toxicity. Now, under normal circumstances, citrate in blood that's transfused is metabolized by healthy liver to bicarb. And so we often see alkalosis in patients who get a large amount of blood, who have healthy livers. However, patients undergoing liver transplant, for instance, whose liver is dysfunctional and get massive transfusion can have citrate accumulate and lead to toxicity. In an awake patient, this would lead to tremor. That's usually not the case in a liver transplant situation. So what you will see is increased cardiac irritability and decreased cardiac output. These patients often have many reasons for those derangements as well, so it's often difficult to pinpoint, but needs to be remembered when that liver is dysfunctional in the face of massive transfusion. Massive transfusion protocol. A lot of different versions exist. The important thing is not what your version is, but rather that you implement one and use it early in clinical situations where you think it might be indicated, and this definitely improves outcome. What kind of outcomes were improved in institutions that have massive transfusion protocols? Total blood product use in the first 24 hours after an incident of trauma, for instance, or other massive bleeding situation. They decrease post-resuscitation organ dysfunction. In one study, up to an 80% decrease in odds of developing multi-system organ failure. Now, this study used a ratio of 3 red blood cells to every 2 fresh frozen plasma and 5 red blood cells for every 1 platelet given. Again, this is not universal. There are many different massive transfusion protocols. That's the one that was used in the quoted study referenced in the slide. Now, at my institution, we have something called Code Red. You pick up the phone, you call a blood bank, you say Code Red. They will immediately put together 10 units of packed red blood cells, 10 units of fresh frozen plasma, and they will also actually call additional personnel in from home to make sure they have the manpower necessary, especially for those fresh frozen plasma units, to start thawing them. I do not work in a trauma center. However, we are a liver transplant center. We also do open heart procedures, and so the Code Red protocol is used quite frequently. In my institution, we use the rapid infusion system. We set it up, prime it for all liver transplant cases, and in this instance, our cocktail of massive transfusion is a filling of the reservoir with 2 units of red blood cells, 2 units of fresh frozen plasma, and 500 cc's of saline. So our ratio is a 1-to-1 as opposed to that prior study again that was 3:2 red blood cells to fresh frozen plasma. We do not have a standing protocol or ratio for platelets. We use hourly thromboelastography to assess platelet function and transfuse them as needed. But again, our reservoir 1:1, along with 250 of saline. Again, not necessarily recommending it, just pointing out that there are different protocols out there, and this is the one that's used in our institution. And with that, I'm finished, and I thank you.